I'm Dr. Emily Silverman, and welcome to Talking Dementia with Remo Health. Join us as we explore the latest advances, insights, and strategies that help empower those living with dementia and the families that support them. Each episode, we sit down with leading experts, from physicians and researchers to policymakers and clinicians, to provide you with the resources needed to navigate this complex disease. I'm Dr. Emily Silverman, and you're listening to Remo. Today, we're speaking with Seetha Bhagavatula. Seetha is a fellowship-trained geriatrician. She got her medical degree from Jagiellonian University Medical College, did her internal medicine residency at St. Elizabeth's Medical Center in Boston, and her geriatric medicine fellowship at Duke. Seetha has worked in multiple care settings, including inpatient, outpatient, skilled nursing facilities, assisted livings, independent livings, CCRC, memory care units, and supportive housing. Prior to Remo, she was a geriatrician at Summit Elder Care PACE in Massachusetts, where she helped elders age in place with an emphasis on quality of life, patient-driven care, and what matters most. Seetha, thank you so much for being here today.
I'm so glad to be here. Super excited.
So Seetha, you've dedicated your career to caring for older adults. So what drew you to geriatrics?
I knew I wanted to be a geriatrician when I was much younger. From like 8 to 10 years old, I actually took care of my grandparents at home. So I got to be a young caregiver with my mom. And they got to live at home for their whole life, meaning they got to be around family. My grandma got to tell my mom, who's her daughter-in-law, how to cook everything until the day that she passed away. We took away our dining room table, and that whole area became a bedroom for both my grandparents. So it wasn't like they were off in a corner. They were front and center. And, my grandma, when my dad would get mad at me, I'd go hide behind her and then she'd yell at him. So I had like that kind of relationship with them. And even despite my grandmother having multiple strokes, my grandfather having Alzheimer's dementia, they really were integrated into our family the best as possible. So when they passed away, it kind of left a grandparent-shaped hole in my heart. And I really wanted to, take care of elderly people. And every time I see a patient these days, I always see them in them. Like I see my grandparents in my patients. So that really makes the bond really special and how I connect to them. One of the things that I saw when I was younger was my grandparents stayed with us for as much as possible. But, there was one time when we had to go away on vacation, and my grandmother, we had to put her in a skilled nursing facility for 2 weeks while we were away. And when I came back, she had lost so much weight and she was so unhappy and her cognition wasn't what it was when we left. So I realized that aging in place is so important, and what the difference is between being at home versus being in like a foreign setting or in, like an institutionalized setting. So that also played a part in what I think about as a geriatrician.
Wow, that's such a beautiful story about your grandparents and what you said about clearing out the dining table and them being front and center. Do you have any favorite caregiving moments or any other examples of because just to be such a young, impressionable girl and to have that experience and to know that you want that to be your career, any other moments that stood out?
I think I really got to see what it was like for my mom, who, in India, she was very highly trained. She was set to be a manager of a big company, but she gave up all that to take care of her in-laws and us four as kids. So I got to watch a lot of her and how she grew close to them and how she helped them, and also how at times she needed support and how that support was seen. And we were lucky enough to have people to come and help us. But in seeing her as a caregiver, there were some interesting situations. One particularly, my grandfather, he was really advanced in his dementia by the time, I was at least relatively older to remember things. So he didn't really talk. He smiled a lot. He needed a lot of help. He didn't move from bed anymore. So we all had to do the dressing, changing, moving. We had a Hoyer in the house. And he didn't really say any words, but my mom one day was cooking and she was singing this old romantic song in our language. And then she stopped and he started finishing the song for her. So my mom felt two feelings. One, thoroughly embarrassed that her father-in-law was singing like a romantic song to her. But secondly, that the magic of music, which is another thing I'm really passionate about, and how that really, despite him not talking on the regular basis, was something that he still remembered and could speak and articulate so well. So that is a story we like to talk about. And it really made me realize that dementia is not just like one tone of like a loss or, a decline. There's so much within that grows and still remains that, sometimes you're lucky enough to see.
I love that story. And I think it's true that music is processed just differently in the brain. And because Alzheimer's, or just any dementia really, is a brain disease, music can be a really therapeutic tool for bringing joy and connection into families. And that's such a great example of that. Tell us about going to medical school, going to residency, going to fellowship. You did the whole gauntlet, the whole training, and that involved taking care of patients in different settings. So the hospital, assisted living, memory care. Can you kind of break down, like, what are those different settings? And I don't know, what was your impression of kind of bouncing from setting to setting and kind of pros and cons of each?
Being a geriatrician, I get to be lucky enough in a certain way to follow people through whichever location they're in. Like when I worked as a geriatrician in fellowship, I could follow somebody from when they were at home, living in a house, to when they maybe needed a little more help and couldn't live as independently or needed help with medications and ended up in an assisted living setting. Or if their cognition got to a place where, they needed some more eyes on and hands on. So they ended up in maybe a memory care unit. In and out of the hospital, I would follow, when they had an acute issue, or if they ended up in a skilled nursing facility, which often happens after people are in the hospital and not moving and very deconditioned, or if they broke something and you have to relearn how to do certain things. And obviously, in the end, in the nursing home setting, if somebody, finally was at a place in their life where that's the best and safest setting for them. But the thing that I learned about all of this is, as a society, we look at people's needs from a perspective of their function, their memory, what they can do from a functional standpoint. And I feel like that's what really creates all these settings. And what I feel is missing, and as a society we really need to think about, is everything else that you need to be a human being, which is mental stimulation, socialization, the ability to continue, your hobbies, your values, to express who you are as a human being who's unique and wonderful in your own way. I feel like that really gets put to the wayside. So when you go to a nursing home, it's really like beige walls everywhere. And what really makes that human, often to a certain extent, is lacking. And to allow that person to have the things around them that make them who they are, at least to a certain extent, is limited. Altogether, these experiences sort of made me feel like there's so much more we can do for our aging population than, in these settings that we do so far.
If somebody isn't able to age in place for whatever reason, functional or family or financial, and they do have to go to a facility, whether it's assisted living or memory care or something like that, what are some things that we can do to transcend the beige walls and make it feel like a home, make it feel like a more human experience?
This is different based on if they're moving into a nursing home and you want to really move stuff. Patterns are really important, especially if someone's cognition has declined. This is why when I take care of patients, even when they're at home, I really stress, get up at the same time, do things at the same time, try to relate different senses with different times of the day. So like if you're going to play a song when you get up in the morning versus a song when you go to sleep, something more activating, something more calming. if you do these things at home, you can mimic them in that setting too, right? I go always back to music because of its amazing retention in people whose cognition tends to decline, and in general. And if there is a song that really means something to somebody, to have it available to them. And if in the home setting, it was played and had a specific moment that it was attached to, or specific time of the day to continue that. Things are also something that we all think about, like pictures, maybe memories of traveling. I had a patient who went to every single country possible, and her wall was full of elephants that she got from like every place. And even though she was really, her cognition was really declining, she could still tell me which one was from where, and it really was a way for her to connect with herself. And then family, of course. Having your loved ones visit, also making that a little bit structured, because to a certain extent, that relationship is important, but sometimes people may or may not remember that someone visited. But I always stress patterns, like really try to do it at the same time. So I feel like it sort of creates a stability in somebody's mind. So you're creating like a home space for them that feels safe. And if there's a chair that they loved, seeing if that is safe to put into that environment. Or, if they love to read books, but maybe their fingers aren't working like they used to, looking at other strategies like putting headphones on and listening to an audiobook. Really trying to make it so the environment is as vibrant as they are.
And before Remo, you worked in a model called the PACE model, which focuses on helping older adults stay home longer. So tell us about that unique model of care.
I think PACE is a really amazing model. The whole idea of PACE is really what I stand for, which is keeping people at home for as long as possible. You have everybody under one building. You have a medical provider who could be a doctor, a nurse practitioner, a PA, your nurse, your physical therapist, your occupational therapist, dietitian, social worker. Sometimes even the home healthcare worker who comes to your home comes from that place. And they're all in one place in the PACE center. And you get this one-stop shop of where you get all the things that you need from those perspectives. There are some consultants that sometimes go there as well, like to take care of your feet, to take care of your hearing, and dentists oftentimes. The thing that I think is amazing about PACE is the way that its payment structure is. You can see a patient as long as you want, as often as you want, with the goal of keeping them out of the hospital, out of the nursing home. And on top of it, you can use your resources as you see fit to keep somebody in the community for longer. So the age-old example is the person who would go to the hospital with asthma exacerbations all the time. And the PACE team paid to have the air conditionings fixed or upgraded, so then the person didn't end up in the hospital as often. And that might not seem like a very common medical intervention, but the overall quality of life of that person, their hospitalizations really reduced because of that. So in that way, we can do what was really necessary for the person to keep them at home as long as possible. And because there is a day center attached to it, which is in the center where all these supportive interdisciplinary team members are, two things often happen. One, they come, they're there on whatever regularity that we think is important for them, whether it's all 5 days or once a week. They get to socialize with who is there and, create a group of friends. They can go into one of our rooms and play chess or checkers or whatever they play and kick us out if they so desire. They have a lot of eyes on them. So if something is happening or there's a pattern that's developing or we have a concern, we see it early. And also, they also feel like they can talk to people, make their concerns known. And the other thing is, if you live at home with the caregiver and that caregiver works, it actually allows for that person to continue to work. They can drop their loved one off, go to work, do their thing, and come and pick them up. So it actually helps with the caregiver continuing their profession, but also in general with their quality of life. So it also creates that experience where there is some feeling of, I have a place to go and I have people to see and things to do. So it really was amazing and really a good way to treat people for what mattered most to them, for sure.
You mentioned the payment structure for PACE and how it might enable you to do an intervention that you wouldn't typically think of as a medical intervention. And it kind of reminded me of the innovative payment model that we're seeing now in dementia, which is called GUIDE. And so in the spirit of innovative payment models, I was wondering if you could tell us about GUIDE, and similar to PACE, like how does GUIDE help us use our money smarter to take care of our elders who are living with dementia?
Yeah, that's a fantastic segue into GUIDE, which is also an amazing model that I'm lucky enough to work with. So the way I look at GUIDE is usually, looking at the example of the world as it is now, where an individual who might be concerned about their memory, or a caregiver who might be concerned about their loved one's memory, or is starting to take on that caregiver role, is noticing that something is off. The journey to that moment to getting a diagnosis is sometimes a really long and arduous journey. And oftentimes that doesn't have to do with actually going through the steps so much as waiting for things to happen. Primary care physicians, as much as they are wonderful human beings, in the system we live in, oftentimes don't have much than 15 to 20 minutes to sort of spend time and to understand. And in that moment, the best they may be able to do is put a referral into a neurologist and say, hey, I want you to get the time you need, please go here. And that can take months. And in that time period, a person is just waiting. And the waiting can be even longer if there's other barriers like transportation. The caregiver can only take them at a certain day, and then that sort of makes it a little difficult to get a sooner appointment, or in general, functional issues that make it harder to go to appointments, right? So CMS saw that there is a opportunity here to support people, dyads, the person who has dementia, and their caregiver in the community, get a diagnosis sooner and get early support. And they were hoping to do it in a way that didn't burden the dyad more. They really wanted to find a way to put this in place where we do more work so that the dyad has a better, quality of life. So the wonderful thing about GUIDE as a model is, number one, you have a team of an interdisciplinary team, similar to what I had said is in PACE, that is available to you, but also includes a care navigator, which essentially helps you get the care that you need, hears what is going on, and tries to connect you with, the individual or the group that'll help you with that. And that is really a good way for us to look at GUIDE as like a middle person. We're not trying to replace a primary care physician. We work with them. We support the dyad in getting the care that they need without them having to change who they see or what they do so much as they would want to, right? And the only way that you are eligible for GUIDE is through having a dementia diagnosis, essentially. There are some other things which are not really for the individual with dementia or the caregiver to worry about. It's really on, us in GUIDE, but that's really basically all you need. And the payment model is purely based on how complex this dementia diagnosis is. And that's it, really. And so it's not really something that has to do with how long you spend with them, how often you see them, similar to PACE in that way. And I'm lucky enough to work in a GUIDE model that is actually fully telehealth. So there's also, you've lost that limitation of transportation and everything. You can see somebody everywhere. So it really allows for people to get the diagnosis earlier, to get the support that they need sooner, have those difficult conversations, have the resources to make empowered, knowledgeable decisions. Because the whole goal of GUIDE is really to help that individual go through this process and not be alone. That's why I feel like in the dementia space, GUIDE is just amazing.
You talked about dyads and how that refers to the person living with dementia and their primary caregiver, usually somebody in the family. I wanted to talk about dyads and something about dementia that can feel a little more emotional. You know, we talk a lot about care and payment models and things like that. But there are a lot of things about dementia diagnoses that really get into spiritual questions about identity. like who are you? And, you know, what does it mean to have a disease that impacts the brain, which is sort of like the seat of who we are and our identity. And that is something that dyads can really struggle with, you know, whether it's the person living with dementia, or in some cases, it's actually more the caregiver who's struggling with that, because sometimes the person living with dementia isn't even aware that they have dementia. So I know that you have spent a lot of time thinking about this question of identity shifting over time in dementia and what that looks like, not just for the patient, but for the dyad. I was wondering if you could tell us some of your thoughts on that.
I'm really grateful for this question because I think that each of us can look at ourselves. And if I was to ask you, how do you identify yourself? Like, what makes you you? A lot of us would look to what we do in life. Who are our connections? What are our hobbies? What are our values? And then you look at somebody who has dementia and you think, how much of that is in that person? And how much of that is actually still defining that person? Having seen a lot of patients with different dementia diagnoses and talking with them human to human and understanding what matters to them and getting to make that relationship with them, I've realized that a lot of what we call identity in our society is actually retained in people with cognitive impairment. There's a large body of research that's come out in the last 20 years having to do with dementia and self-identity. And the consensus is that people who have moderate to severe dementia diagnoses still tend to maintain a definition of self from the perspective simply they use I statements, they can personalize things, they still have specific interests, and that still retains. And I think a lot of us define ourselves by what we do in our job. Studies have shown that actually that's one of the first identities in people with dementia that tends to go away. Oftentimes the one that goes away first and is oftentimes something that is accepted quite well. The identity part that really seems to be the most resilient is people's relationships. So how they identify themselves through their loved ones, their friends, their community, that tends to preserve even when the dementia gets more and more advanced. So I think that the interconnected strings that attach all of us are still there when people's cognitive impairment worsens. And I think another part of this that's important is how people see the person who has dementia and how they interact with that person. You know, it's really hard to watch somebody go from who they used to be that you knew to who they are now. And a lot of us, rightfully so, focus on that gap. And that is difficult and that is really hard. And it sometimes makes it really difficult for us to talk to that person as if that person is still there. You know, we talk about ambiguous loss in dementia, the idea that the body is still there, but the feeling that they're not there on the inside. But I think a lot of the data suggests that if you talk to that person and approach them for what is retained, they actually maintain their cognition better than if you approach them as somebody who's impaired, not themselves. Sometimes people talk down to them, for example. And so I feel like really how you approach people who have dementia is super important. And I think that there's a lot of research to be had and a lot of awareness to be done about this.
Yeah, that's such an interesting point, that if you approach somebody with dementia as if they're already gone, that, you know, they might pick up on that and behave accordingly. Or if you approach them as somebody who still is in there, that might actually impact their behavior. And I don't know, I'm wondering, like, when you're sitting down and talking to families, do you ever coach them on, like, this is how you talk to somebody who has dementia? This is how you interact with somebody who has dementia? Because I think it's really easy to fall back on that pandery, like sing-songy, almost like a kid voice. And I'm curious, like, how do you tell or guide people on that?
So there is something that I like to say a lot, and it's to everyone, to caregivers, is the person that you are inside and the person that that person is inside are very similar. You know, we have a shared humanity. Just because the outside gets more and more old, the mind starts to decline, that person on the inside still has wants, fears, desires. You know, a lot of them want to do what you want to do. They look out the window, say, oh my gosh, I'm so bored. I want to go run out there. I want to go do this. I would love to eat this. Things that make you feel, I want to do this, I need to do this, exists in that person. Sometimes I simply say the 30, 40, 50-year-old that you are is the 30, 40, 50-year-old that this person is on the inside. So trying to strip away what we see and infer from what we see and seeing the human that's on the inside. Do I say this to caregivers the first time I meet them? No, but I, in front of them, always talk to the human that is in that person in front of me. And that's really allowed me to create such magnificent connections, really knowing who they are. And then they, in return, will be more open to who they are with me. And I think caregivers sometimes see that and realize maybe this is something I should inculcate. But of course, I've said this to people too at some point when I feel like the relationship is at a place where it'll be heard.
And how do you coach families to focus on what matters most? Like, I think those are three really powerful words that I hear people in the geriatrics community say again and again, is like, what matters most? What matters most? And so how do you keep coming back to what matters most and make sure that all the care is driving toward what matters most?
Yeah. I think something interesting that you learn in medical school, and I'm sure you can relate, is we are always taught to preserve, protect, and prolong life. That's what all of our exams are about and everything. But then when you go into this space, you realize that that is as much of the goal as that person wants it to be. So to me, what matters most is preserving and protecting what matters for that person. And it could be anything. And it could be challenging to find out. The person could tell you immediately. And that sometimes is difficult because of their previous interactions with doctors who may or may not have had that approach. It can be as simple as, I want to see my granddaughter graduate, and she's graduating next year. I want to walk it to the bathroom until the day that I die, you know? Or I love to read books, and that's a big part of my life, and I want to keep going. And these things might not sound like big medical things that we should be talking about, but when you take all these things that are seemingly small, they actually tell you something about that person. When you talk to them about their lives, you know, what was exciting for you. I recently saw a patient at Remo, and she was not talking. She wasn't saying a thing, and her whole family was talking for her. And it came up that she loves to travel. So I just stopped all my questions and looked at her and said, where was your favorite place to travel? And she's been all over the world. And she said, Myrtle Beach. And I said, that is great. That is awesome. What did you like about it? And she slowly came out of her shell. And she was telling me about what she loved about Myrtle Beach, and then turned into what she loved about Italy, and then turned into, hey, yesterday my husband took me to this karaoke thing. And I said, were they good singers? Were they not good singers? Right? So she opened up. She was more vibrant. She was having more of a conversation with me. And through this, may not happen right away, but as a clinician, you get to know the person. So when you have the conversations that are tough, you know, like your memory is declining, and at some point you might not be able to drive. At some point you might not be able to speak to complex decisions. How do you see your life going is an easier conversation to have, because you also, to a certain extent, recognize what's important to them. So you can say, I know it's hard because you're so used to being the mom who took care of your kids and like drove them everywhere and called all the shots and didn't take anything from anybody. And you see them from where they're coming from. So I personally don't know how you can give tailored patient-centered care without actually coming from the patient center.
Being a caregiver can be really challenging. It's emotionally draining, physically draining, financially draining. And so I'm wondering if you could spend a minute to speak directly to the caregiver and any advice you have for them as they navigate what can be sometimes a short journey, but sometimes actually quite a long journey. It can be decades. So how do you prepare people for that? And what do you say to people when they're just starting out on that process?
As much as dementia is a diagnosis that tends to consume the person with dementia, caregiver is a definition that tends to start to consume the individual taking on that role too. So it is a very challenging thing to do, especially when you've lived your life also a certain way. And you may have called your own shots. You may have lived your life as you wanted to. And now, a lot of what you do is revolving around somebody else's well-being. And a lot of what you can and cannot do is revolving around that. So it is a transition, a huge life transition that I feel like as clinicians, we definitely need to pay more attention to and support the caregiver more, hence why the guide model is so awesome. What I usually say to caregivers is, don't wait until you're burnt out to ask for help. Our mutual goal is that we can take care of your loved one in the community for as long as possible and make that as happy a situation as possible. And if you are working yourself for whatever reason and not asking for help, your ability to take care of yourself declines. Therefore, your ability to take care of this person declines. And that person who also loves you will see what you're going through and feel that feeling inside them that this person is going through so much to take care of me. And that energy makes it much harder, especially when you have additional medical things happening or additional family things happening to adjust. So what I say to caregivers is don't wait. Feel empowered to give yourself a day off. Have a plan. You don't have to wait until you're like, oh my goodness, I need a break. I need to take a break. Don't wait for that. Really lean on people who you have in your family or your surrounding loved ones, if possible. Your medical team. There's a lot of strategies to do this. And I know that there's a lot of feelings of shame for asking for help, a lot of feelings of weakness to ask for help, or I want to be able to do everything myself. And I agree. I want you to be able to do this yourself for as long as possible. But it takes a village. And let's not wait until things are critical to ask for help. And what that also allows for is allowing other people into the care in small ways, allows them to see what it's like too. So if something were to happen and you're not able to take care of them, you have individuals who are like, yeah, I've done that. I know how to do that too. And it also sort of shows them what is happening, and they also walk with you in this. And if difficult decisions need to be made at some point, you have individuals who not only care about that person, but have also seen a lot of what has happened and have a more informed way of helping you and supporting you in making decisions. So that's usually what I recommend.
Any unexpected or surprising moments from your work that you would love to share with us?
So remember when I talked about like what we learned in medical school and what happens in real life, especially in my world? So I have a funny story for that. My first patient in PACE, when she came in, she couldn't even talk a sentence. She was so short of breath. She had heart failure. She had lung issues from smoking for a really long time, and her kidneys weren't functioning really well. And that combination made it just really hard for her to do anything. So I did the doctor dance and made sure that, all her medications were good, her diet was good. We did all the preventative things, and she got to a place where she could say a lot of sentences and she could live her life a little more independently, which was great. Her prognosis in general, based on everything that was happening, we knew and she knew was quite poor. So she looked at me and I said, okay, what matters most to you? And first thing she said is, I want to go to the casino. And I said, okay. So I think I'm the only doctor that I know of who went to my group and said, hey, can we arrange transport to go to a casino? And, my group was very kind. They said, I can see what you're trying to do, but no, we can't do that. So the wonderful team and I, what we did was we made sure her driver's license was up to date so that she could get in. We talked to her sister who lived in the neighboring state and said, when are you coming down? We made sure that everything to do with her oxygen, that she's able to go there and not have to have issues with the bathroom. We made sure all those things were done and she was able to go. And she was so happy. And then another thing was she said, I want to play bridge with my friends every week. And I want to eat greasy, salty food with them. And I had my risk and benefit conversation based on her heart failure that these foods, delicious as they are, and as you have a right to enjoy them, can increase your risk of your heart failure getting a little worse. Had the conversation, she understood it. I gave her an extra pill to help with the fluid that night and said, just take this, come and see me the day after or 2 days after. You can come see me every week after this and we can chat about your game and whether you won or lost, which she didn't like because she always won and she didn't want me to say she would ever lose. And we did that. And actually, both of these things together really made her happy. And because of that, she was more inclined to have a positive outlook on what was happening in her life. She was more quick to tell us if something was wrong because she wanted to fix them. She was very good with her physical therapy. She would come and see us more often because we were also not only caring about medical issues like how's your heart failure numbers looking, how's your weight looking, but also how are you feeling, how's life going, is everything good? And she lived for about 4 years after that. I mean, not like we have a crystal ball to know how it would have gone otherwise, but she lived good years. And I like to think part of it is obviously taking good care of her medical diagnosis, but a huge part was knowing who she was and what made her happy, and that we were invested in her being happy. So I always think about her whenever people are like, well, I don't know if I should tell you this. This makes me really happy, but I don't know if it matters. I will say, please, just tell me. I have had people say they want to go to the casino. I've had people say they want to eat really greasy food. Just tell me, because I'm more than happy to work with you.
Seetha, I'm wondering if you can talk about the value for the caregiver in the guide model.
Yeah, that's a big piece to guide that I think is really important to talk about for sure, is there's, in general, like simply, there's two entities moving with this together. There's the person who has dementia, and then there's the caregiver. And a lot of times we focus a lot on the person who has dementia and not really talk about the caregiver. But the caregiver oftentimes is the five senses for this person, the keeper of all information and appointments and medication changes and everything, and having to keep all that going and understanding what is happening at each appointment. And that's really overwhelming. And I think something that Guy was phenomenally smart to talk about was, how do we support the caregiver? Like, how do we give them what they need to be successful as a caregiver and as a person themselves? So guide in itself, one of the things that, at least at Remo, we pride ourselves for is having a large amount of information that we can give to the caregiver as slow as possible, as quick as possible, tailored to what their concerns and their questions are. Because some people will come to us being like, I have no idea. I've never heard of this before. What can you tell me about it? To a place where it's like, yeah, I mean, I took care of my father and he had this too, but this is completely different and I don't know what I'm supposed to do with this. Or, this person has a specific way that they're moving throughout the day that I don't understand. Or why does this doctor keep talking about DNR? What does that mean, right? And these are really important for the person with dementia to have the best outcomes, that everybody around them is all on the same page and understands, so that they're empowered to make meaningful decisions aligned with that person's wishes throughout the whole journey. So Guy gives that, and also in general, the ability to take a break. There is a certain amount of respite baked into that, depending on the severity of the dementia. And what that means is either at home or in a day program or in a facility, depending on what is the need and how often, or if it's just a one-time thing, it's available in there to a certain amount of time limit and a certain amount of, need. There has to be like a specific need for that. But the advantage of that is the caregiver can take time off. Take time off earlier if you can. Try to do this before you get burnt out. And I think Guide really speaks, to that and really gives some solutions to that or some support that would make that possible.
What drew you to working at Remo?
The telehealth space is really awesome right now. And I love it to the extent that I can see somebody on one side of the country and then see another person on the other side of the country. Being in their house on video and seeing what is happening and seeing the interaction. So to a certain extent, I feel like I'm in their house. So that in itself, I thought was amazing. The thing about Remo was everybody who works at Remo are just fantastic and all grounded in the same belief that we should be providing empathetic, patient-centered care to people with cognitive impairment, and they walk the walk as much as they talk the talk, right? And I've worked for really large corporations, and, in that way, it's kind of hard to be creative and authentic to a certain extent, especially if there's bureaucracy or administration-related things. But I really see in Remo that from the ground up, they're trying to build something with the puzzle pieces being the people really entrenched in that goal. And it's really amazing to work with people like that every day. And that's why I'm here and that's why I'm going to stay. Because I feel like as a team with that same energy, you can only give the most amazing care to people.
And as we bring things to an end, I'm wondering what you see in the future, dementia care over the next 5, 10, 20 years. What would you like to see?
I've spoken about it in this talk, like little bits at a pieces, but I'll put it together, is the awareness of what dementia is and what it doesn't have to be. I feel like I want to see that become more pervasive. I want generations to look at people who are older in general and not just see, oh, this old person with their old thoughts. I want them to see the person in them and really interact at a person level. I think with how amazing telehealth is and in general, the understanding of what it means to age, especially in the medical community, I've seen such amazing improvements over the past 5, 10 years of knowledge about how to take care of older individuals and geriatric syndromes, for example, that it just gets more and more understood. And that from a telehealth perspective, we're able to give care left and right, and there's nobody left out, that anybody who needs care, that is there for them. And I also want to continue spreading that word that the way you approach your patient or your loved one who has dementia is so important to their self-worth and their self-identity. So I'm hoping that with time, we're also able to build that better. And in general, make our models of care, make our structure of care, make our locations of care more patient-centered, more human-centered than it is right now.
Thank you so much. I have been speaking with Dr. Seetha Bhagavatula of Remo Health. Seetha, this has been a wonderful conversation. Thank you so much for coming on the show.
It was so much fun. Thank you for having me.
Thanks for listening to Talking Dementia with Remo Health. If you're looking for more information, resources, and expert insights, visit remo.health and subscribe so you never miss an episode. Until next time, take care.